Good morning, everyone. I'm Dr. Sudhir Sapkota, and I welcome you all to our second last session of this Pediatric Palliative Care Eco 2. And we are proud that we are together here for 10 months already. And for today, we are going to discuss on the end of feeding and fluids at the end of the life. For today's program, we'll be having 20 minutes of discussion by Dr. Peter Louis, and it will be followed by 20 minutes of breakout session. And in breakout sessions, all of the participants provide will be kept in different rooms, and Dr. Megan will be doing that. And in each room, there will be one of the senior participants or the senior faculties who will be guiding through the process. And hope that you all have gone through the cases that we had provided you in the WhatsApp. So there will be two cases to be discussed in the breakout rooms, and each case, as far as possible, we can allow 10 minutes for each case. So right after the breakout room, we'll choose one cell portion from each group, and they will just summarize what had been discussed in the group, and it will be followed by further discussion among the other participants and the faculties. So before starting the today's program, I'd like to say happy Sivaratri to all. Hope you all will have a warm evening today and have a fasting throughout the day. So, bef- without much delay, I would like to welcome Dr. Peter Louis. He will be speaking in feeding and fluids at the end of the life, and he's a pediatrician and a palliative care expert at Vancouver, Canada. And hope that you all have gone through the video given in the WhatsApp group by the Dr. Megan. So, in addition to that, Peter Louis will be discussing about the other aspect in feeding and fluids at the end of the life. Over to you, Dr. Peter.
Thank you, Sudhir. Can you hear me?
Yes, you are audible. Please go.
Okay, I'm going to share my screen. Can you see my screen? Good. All right. Thank you, everybody, for joining today, and good morning, and thanks for joining, even though it's a holiday for you. I'm glad that you're able to join, because this is an important topic that we deal with regularly, and the reason being is because feeding, eating, nutrition, and fluids is such a basic part of life that we all need to nurture ourselves, to grow, to develop. And when this cannot happen for a family, or if doing so causes more distress, this can be very difficult for families. So we wanted to be able to, with this session, with what you've learned from Megan's session, be able to understand a little bit about what is happening as the disease progresses in these conditions, and also help you in supporting the families. So what we'd like to do, and you've watched Megan's presentation, I'm going to expand on some key points, and then I'm going to talk more about family support. So what I'm going to do is talk a little bit about medically what is actually happening that's affecting the eating and the feeding and the weight loss. I'd like to understand where the family is coming from, and why what their goals are with regards to eating and feeding. And we'll look at what some of the adverse effects or the discomfort that overfeeding or excess fluid can cause for the child, and then be able to explain some of this to the families and be able to support the families when feeding is not in the best interest of the child. So at the end point of many different diseases, whether it's cancer or whether it's organ shutdown from a child with asphyxia or severe cerebral palsy, we often encounter this phenomenon called anorexia or cachexia, and so it's helpful to be able to define it. So anorexia, the definition is basically a loss of appetite or lack of interest in eating, and so it's easy to appreciate this, because anytime that we're unwell, or if we have a cold or we have a stomach flu, for that period of time, we don't really feel like eating. We don't feel good. And if we eat, we feel worse. And so therefore we eat less during that time. We might drink more fluids, but in this situation, it's something reversible and we get better. But with the conditions that we're talking about in palliative care, most of the time these children are progressing and they don't get better. In addition to the decreased appetite, there's a phenomenon also called cachexia. And what this means is two parts to it. One is that the body is not able to absorb the food very well. And then even though it's able to take in this energy, it's not able to use it properly. And with the disease progressing, it increases the body's energy needs. And at the end of the day, it starts breaking down certain things and putting our body into excess energy requirement. And then we start breaking down fat and muscles, and this contributes to the weight loss. So at the end of the day, what we see is first there's decreased intake. And even though even the food that the child takes in is not being able to be absorbed properly by the body, and the body is also breaking down muscle and fat, which normally doesn't happen if you're not eating as much as extensively. And ultimately, this results in weight loss. And then, and this is what we call anorexia cachexia syndrome. And so the primary cause is the underlying disease. And so at least 40% of children with cancer will experience this, and most adults with cancer will experience this. But it's not only cancer. Like I said, other children who their disease is progressing and they've had recurrent infections, recurrent illnesses, they can also experience this phenomenon. And then it's not reversible with fluids or nutrition, because you would think that if you're losing weight and you're getting weaker, it would make sense to give more fluids, to give more nutrition. But in this case, that extra fluid and nutrition is not going where it needs to go. And despite that, the body is breaking down. However, sometimes there can be secondary factors that could make this worse. All right. So we can't do anything about the primary process, the underlying disease or the cancer getting worse. But if there's secondary factors, like if the child's having a lot of pain, it takes a lot of energy to be in pain. And so if we can help the pain, maybe we can help a little bit with the weight loss. If their seizures are getting worse or their tone is getting worse, helping with that will decrease energy expenditure. If they're breathing, having difficulties breathing, if they're fighting an infection, or if there's medication that can be causing nausea or slowing down the stomach or constipation, we might be able to help with that. And then with that, it's something that you're helping to reverse, so that you're actually, the family is seeing that you are doing something, you are trying to help the child get better. And so often what families think is that if you don't give them food, if you don't give them fluid, and they see their child, and this is very difficult as they're getting skinnier and skinnier and they're wasting away, they think that their child is starving. And so when they feel that, or they think that that's going on, obviously that's going to be a lot more worrisome for them. So I put this chart here to try to help them understand and differentiate between what's the difference between starvation and anorexia cachexia syndrome that we've been talking about. So when someone is starving, which means that their body is not getting enough energy or food, then what they do is your body really tries hard to conserve yourself and stay healthy. So it's going to start to break down fat first. And then after it uses all your fat, then it starts to break down muscle. And then when it uses all your muscle, then it starts to affect your organs. But in the case of anorexia cachexia syndrome, whether you take in the food or not, the body doesn't know what to do with this, and it's breaking down things that it shouldn't be breaking down, your muscles, your fat, and your organs. So it's causing all this breakdown regardless of what you eat. So to be able to help the family understand that they're losing weight not because they're starving, but because it's the disease process itself. So why is this important? It's important because food and nutrition is so important to all of our lives and all of our and it's such a big social aspect of our lives. And all families want to nurture their child, to offer them nourishment in order to grow. And meal times are very important. And and then when they see that they try and it's not helping and they're wasting it away because of this anorexia and cachexia, it can cause a lot of distress to the families because they don't really have control of what's happening. And because you'll see in the next slides coming up, by overfeeding or giving too much fluids or nutrition, this also results in side effects, which is also impairing the child's quality of life. And of course, it's very difficult to see the patient lose weight over time. And so by understanding where the parents are coming from and what their goals are, it's helpful to know how to support them or how to educate them. So one is that we've already talked about this. If they think that their child is hungry or is starving, we can explain that this is not necessarily the case. Some families or most families would say, well, they're weak, they have no strength, so we have to give them more food in order to get them more strength. Or they were walking before and now they can't walk, so we need to give them more food in order to build muscle and help them walk again. And so by explaining that it's not the food that's going to help, it's the condition that can be helpful. They feel that the child needs more strength in order to fight the disease, more energy. And sometimes it's almost like describing to them, by giving them more food, we're essentially feeding the cancer, and it's not helping with the weight gain. They feel that the child will live longer if you give food, and if we take this away, they'll pass away sooner. And 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 that if they're not able to feed, then they're essentially giving up and nurturing. And so that's why being able to explain to them what is going on is so important. So we know that parental nutrition, which means IV nutrition or nutrition through a nasogastric tube, it doesn't help, as we're saying, if they have this condition, and that it increases morbidity or it increases their discomfort. And we also know that fluids at the end of life, and when I mean end of life, I mean months, weeks, months, or days, they do not prolong life, and it does not reduce thirst, hunger, or dry mouth. There's many metabolic processes that are happening in your body when many systems are breaking down, like electrolyte abnormalities, increased creatinine, increased urea. A lot of those things are going to cause thirst, and giving the fluids isn't going to change that necessarily. And so, however, not only is not helping, it can potentially also cause a lot of side effects. Because what ends up happening is when you give all this fluid, it's going to start to go places that you don't want it to go. And one of which is the lungs causing pulmonary edema, or the intestines causing ascites, or the legs causing edema. And when the gut is not working properly and is not absorbing properly, and the stomach has slowed down because of decreased gastric emptying due to the condition, by putting food down, you're causing more nausea, you're causing more distension. And when food is sitting in the intestine and not being absorbed, bacteria start to digest it, causing a lot of gas, causing a lot of bloating, causing a lot of discomfort. So the way that I usually explain this to families is that I say to them that due to the whatever the disease, you can put that in, due to the cancer, due to the brain injury, and the progression of the illness, your child's many of your child the organ systems are starting to slow down and not work quite as well. So, for example, the heart isn't beating as strong as it is before, and the kidneys are not filtering the fluids that we take in before as well. And therefore, if we put in the fluid, give the IV fluid or give more fees, what ends up happening, if the heart is not beating as strong, then the fluids go places like the lungs and cause breathing issues, or goes to the tummy and makes it more distended, or goes to the legs, making it more painful or difficult to walk. And if the intestines are not absorbing as well, and then by putting food in, they're going to feel nauseated. They might vomit. They just feel more uncomfortable. The other thing for us to know is that if you increase fluids, you can also increase urine output if the kidney is still working, right? And in this case, if a child has increased urine output, that might affect their peritoneal care. It could result in more skin breakdown. It could result in ulcerations, and it can make the care more difficult. And then it might necessitate the need for a catheter, which is another intervention which has side effects and also affects where they're cared for as well. And then also having an IV running fluids also affects where you are, because it's a little bit harder to get home if you're dependent on IV fluids or has an IV. And all of this contributes to financial burden if they're going to need to stay in hospital longer or pay for these things, or have to pay for feeds if the child is getting nasogastric feeds. So how can we help? And so it's hard to not have any control and not be able to help with feeding. But like I said before, maybe there's some reversible causes or secondary causes that we can help and work together with the family to say, okay, well, why don't we see if we can, more radiation can shrink the tumor, provided it's not, provided it can help. Can we treat infection? Can we treat pain? If there's intestinal obstruction, can we help with that? Are there medications we can help with the nausea and vomiting? If there's difficulty swallowing, is there ways that we can thicken the feed or help with the swallowing? And so, like I said before, we can help them understand that this is not part of the dying process, that is due to the metabolism, increased metabolism in cachexia, not due to starvation. It's not reversible, and giving more food isn't going to help. We can also help the family understand that, like, the side effects in terms of increasing intake can cause more distress, that giving NG feeds is not going to prolong life and has its own risks and harm as well. And then you want to find alternatives, right? So if we can't do this, what are other things that we can do? So and especially for our nurses, a lot of these discussions and a lot of these interventions are part of what our nursing colleagues are doing all the time at the bedside. You can keep the mouth moist, you can keep the lip hydrated, and this can help with comfort and thirst. They can have small tastes, and they can have smell the food, and then you can focus, shift the focus to enjoyable foods, things that they really want to eat. And then you can look at other activities that don't necessarily involve eating. And so what are some of the things you can say? So again, it's not something that we can change. So sometimes emphasizing or acknowledging that it's difficult can be helpful for the family, and they see that we understand, and that they see that we know that it's difficult for them. So saying things that, like, I can see it is difficult for you to watch your child becoming thinner, eating so little, or perhaps this is time to focus on eating small amounts of things that are most enjoyable. What are her favorite things? It must be hard not to bring him food when you have fed him and nourished him for years. What are other things that you can do for him now? Your son is not dying because he is not eating. He is not eating because he is dying. And so what are other activities? So you can ask, what are other things that you can do for your daughter that expresses her love and care, or your love and care? And what can you involve your daughter in, which is when she's unable to eat but wants to be with you? So can she be part of mealtime but not necessarily eat and sit with the family? Can she help prepare anything if she's capable without necessarily eating the food? Sometimes, as Dr. Megan has mentioned in her talk, regardless of what we say, and this goes for many different interventions, not just food and fluids, the parents want to try, and it's okay if they want to try. But I think the most important thing that we should know is that we should anticipate this as early as we can so that we can try with them. So we don't want to wait until the child has a couple days left, where we have many, many days where we're forcing feeds in when they're uncomfortable before we try anything. And we don't, and in those situations, we don't have time to wean or negotiate with the family. So for example, they might say, we want to try IV fluids. And so I might say to them, well, why don't we try? We can run some IV fluids. And I understand that your goal for running fluids is that you hope that they'll have more energy, they'll be less thirsty, and maybe they'll be more awake and be able to move around more if they have more fluids and hydration. So those are your goals, and we can try and see if it helps. I worry that some of this fluid might not go to the right places. So it might go to the lungs and cause difficulty with breathing. It might cause more swelling in the legs. Um, and with children with brain cancer with increased ICP, you can also say there's a lot of fluid in your brain, and our brain is made up with quite a lot of fluid. And if we give more fluid, this will also go to the brain. It can increase the pressure, and it can cause more agitation. It can cause more headaches, because if there's more pressure in the brain, they feel better if they're a little bit dry. So therefore, you know what you're trying to achieve, you know what can happen. So then we have an understanding. So you start the fluid, the next day you assess, well, did it help? If it helps, fine, continue. Or did it cause a lot of side effects? And if it does, then the parents will know what they're looking for. And then you'll be able to negotiate and say, okay, well, why don't we try to decrease to 50% of the rate today? Or 25% of the rate. And then a lot of this discussion back and forth is also with nursing and the parents, right? So if you give we might write a range for our nursing colleagues and say IV rate of this to this based on comfort, and then they can adjust it up and down with the family to be able to trial. The same thing goes with feeds. So if you had already started this discussion many, many weeks in advance, often parents start to drive it. So they'll say, we noticed that yesterday when we were running this feed rate that they were uncomfortable and they were more bloated and they were vomiting more. I think we want to try to decrease a little bit today. And then I might say, okay, well, why don't we try that? And then a few days later, I might say, well, they can't tolerate that concentration of feeds. Why don't we try to decrease it by half feeds and half water or half Pedialyte? And so then they kind of make the decisions with you. And then they also feel that they're controlling the situation and that the same goal is that you're trying to achieve comfort. The exact same thing happens with transfusions. So especially with our ALL and AML families who are used to blood transfusions and platelet transfusions at a certain number. So by the time, if the hemoglobin is this number, we want to transfuse. If platelets are this number, we want to transfuse. And if you have this discussion with families in advance and say, we will continue to do the transfusions if they help, but at some point I worry that they're not going to help as much, but they might cause more problems because the fluid is going to go places that we don't want it to go and cause breathing problems and swelling, all of the other things we talked about with IV fluids, but with the transfusion. And then if that starts to happen, we might need to give the transfusions less frequently, or we might need to transfuse a lower volume. But I'm happy to continue to do the transfusions if we see that it is helping. So again, so you need to anticipate. So you don't want to wait until it's too late and you have to suddenly stop everything and have the child uncomfortable for a long period of time already. You want to anticipate so that you can guide, you can discuss, you can negotiate. And this will help to minimize distress. You want to find ways to feed for pleasure, more frequent meals and other activities you can nurture. And then you want to see if there's things you can do at the bedside, especially with nursing, with moistening the mouth, ice chips, sponges, gentle brushing of the teeth to provide good oral care, monitoring for Candida, Vaseline for dry lips. And so it's just to conclude, it's very difficult, but being able to anticipate in advance and educate the family and be able to explain to them and work with them to achieve the common goal of comfort. If you do that, you often find that the families will agree with you, and as long as they understand. So what I'd like to do is now we can soon go break out into the two cases. The first case I chose for you is an oncology case, which I think most of you would be familiar with because you have more experience with oncology. And the second case I've chosen is a child with cerebral palsy, which due to recurrent illness is deteriorating. And then so we can discuss further in our small groups about how to support these families.
Okay, I'm gonna put everybody into the groups now. And please accept your group. And if you're not in a group, I'll be putting you in one very quickly. So just give me a minute. Hi, everyone. Welcome back. I checked on most of the groups. Just a reminder, just in case there's something you're not putting now. Cooking or walking or something. So. Okay, Sudhir, do you want me to wrap up or are you gonna give a few last comments?
Megan, so if you have the list, can you ask someone from the group to summarize?
Yes, thank you. Sorry, I forgot about that. Okay, so going by groups, so I'll call on somebody from each group. And if you weren't able to join your group, I know there was a few people who had trouble or couldn't contribute, then just say, we'll call on somebody else. So from group 1, I'm going to call on Sumit Agrawal. Sorry on the names, I'm not good.
Dr. Sumit, are you there?
I think he was having connection problems, he put in the chat.
Anyone else from
Okay.
that group? Anyone else was in group with Dr. Sumit?
Maybe Angela?
So, okay, thank you. In the first case, the case of child with rhabdomyosarcoma with maxillary sinus, there was the primary tumor in the maxillary sinus, and then it had pressure effects, especially in the oral cavity and in the oropharynx, causing difficulty in feeding, and he had pain also. So we discussed that to improve his symptoms, we would give him some pain management, and then maybe he had undergone chemotherapy and radiation therapy also. So we expect some mucositis contributing to the difficulty in feeding and managing the secretions. So we could address that also, and then optimize the dose of analgesics and also give some breakthrough doses if required. And then we have to assess whether feeding would be helpful or not. But in this case, since he has constipation and has pedal and scrotal edema, maybe decreasing or discontinuing the IV fluids and then giving a small amount of feeds orally could be helpful to the child.
Perfect, thank you. So I'm going to call on somebody from group 2 now. Just a reminder, if it's already been said, don't repeat the same point. Give one additional point from your group. So for group 2, I see Juna. Dunkana, were you able to contribute?
Megan, Dr. Bishnu was gonna
Oh, perfect.
Yep.
Please, Dr. Vishnu, sir, go ahead.
Thank you very much. We had discussion on the first case, and sorry. Many of the things are same as said in the first group. If the child can take soft food, would be the best. If not, and if there is a possibility of putting a NG tube or orogastric tube without causing any further discomfort or injury, that could be one consideration. But if there is any probability of injury or discomfort, that is not in priority. And to keep IV fluids to minimum or nil until the child stays in the hospital, and respect the will of the child to go home. Stop all the IV fluids if needed, and remove the NGTV if the child is not comfortable with it, and respect his will to go home, and tell the family that the team in the hospital is always available for any needs of the child at any point of time. Thank you.
Thank you. I really appreciate the point on respecting the child's wishes. I think that's so important. Okay, from group 3, I'm calling on Dr. Sani. I'd like to hear from you for your group, perhaps.
Thank you, Dr. Miguel. Most of the things has been said earlier. I would just like to add up the things that we discuss is the patients. We need to hear from the patient party, the family, and more about the communication that we need to deal with the family, because when child is not eating properly, the family are more concerned about feeding them or giving them food. So we need to communicate well with them, discussing about what are the current condition and how we can improve the child's feeding. Thank you.
Thank you. Thank you for adding that point. So maybe for the next groups 4 and 5, we'll ask for comments on the second case, because I think we've covered majority of points for the first case. So in Dr. Ishak, he was in room 4, so I'm going to call on Dr. Srijana. Can you share from group 4?
The case about 12 years old child with cerebral palsy, severe cerebral palsy, and repeated admission in the last 1 year. And the things that we discussed in this case was that the child might be having a lot of has been having a lot of admissions with the infections and respiratory problems, and that might be one contributing factor for increased energy and leading to decreased weight. And other is that even with the increasing amount of food through the feeding tube, the child is not gaining weight. It could be because of increased energy and loss of weight, leading to anorexia cachexia syndrome. And the other is that child cries during feeding. It could be because of risk of, and there is a lot of risk of aspiration as well through the feeding tube. And it could be because of pain or the child having difficulty in swallowing. And the other thing that we discussed in this child was the child might be having gastroesophageal reflux, GERD, which needs to be treated. So we discussed about some of the treatment for this condition. We talked about the PPI and the H2 blockers, and positioning of the child, especially positioning of the child during feeding might also help, might also be helpful.
Positioning is a good point. Yeah. Good. Thank you. Some really good points there. This is a complicated case, and I know that many of our participants are not so familiar with non-cancer conditions at end of life. So this is challenging for all of us. I'll just ask from group 5, if Muna, if you can share a few thoughts, anything that you heard that hasn't been said about the second case. Is Muna, are you there? Other people from group 5 we've lost the rest of them. They dropped off the call. They don't have anyone else in group 5, unless Sudhir, do you want to say a couple things about what happened in our group?
In the last group, in addition to what we have discussed, we discussed about the management of the secretions also. And so in management of the secretions, though we use suctioning of the secretions in the hospital, rather than that, we can also go for the using glycopyrrolate, or we can use the atropine, which is actually available in the eye drops or other forms that can be used locally, so that the secretions will decrease. And so that was something we discussed in addition to all the points mentioned above. Over to you, Megan.
Thank you. Thank you. So I think those are all the groups that we had. So we had some really good discussion in the groups. And I feel that that's really good to hear everyone's point of view. So hopefully you were able to share in your groups. Any other points from faculty that Dr. Peter or anyone else who was in the groups wanted to just raise before we wrap up for today?
Okay, any queries from the participants? Any last question, because we are running late? Any queries from the participants? Otherwise, we are going to wrap up today's program. Okay, so everyone might be busy preparing for the celebration, and so we won't like to take much of your time. So thank you all for your participation, and this was a wonderful, wonderful discussion, right? And in spite of your busy schedule and your holiday, thanks for participating in the program. Thanks you all, and we'll meet again in the next session, and that will be the last formal session for this ECHO 2. Thank you all for taking part in this program. Okay, bye-bye.
Thank you for the great discussion. Have a good day, everyone.
Thank you, Peter.
Thank you, everyone.
Thank you.
Have a
Thank
wonderful
you.
day.
Faculty
Enjoy the holiday.
will meet for the debriefing.